Hello everyone, my name is Dr. Ashraf and today we will do a case for inferior wall myocardial infarction. Your patient will present with new or worsening chest pain, very acute, retrosternal or squeezing pressure-like pain. The pain would radiate to the arm, to the neck, to the jaw. They could have dyspnea and the pain would relieve by rest or nitroglycerin. They could give you history that the pain is worsened by exercise. Um, there could be a history of vasovagal symptoms like nausea, vomiting, and syncope. And the pain could be atypical in nature as well. So, in case of females, diabetic, and elderly patients, um, they can present with epigastric pain, back pain, or burning or a stabbing pain as well. So, moving on to the physical examination, you're looking for a general appearance of the patient. So, comment, my patient is pale. I can appreciate diaphoresis. Ask for the vitals and mention that your patient is hypotensive, um, bradycardic, tachypnic, and hypoxic. So, hypotension because of can be present because of right ventricular involvement, and bradycardia can be present due to the involvement of SA or AV node. Okay, and then you will do a complete cardiovascular examination. Please mention that ideally I would like to have a full exposure to inspect the precordium, and when you're auscultating, mention that you're finding a murmur, and also look for the JVP. So the examiner might give you a finding that that there is elevated JVP. Also look at the lower limbs to assess for pedal edema, and listen to the chest for any crackles or rails. So what would be your next step? First and foremost, ask for a serial ECG, and here you'll get to know when the examiner will give you findings of hypotension and bradycardia. You'll get a little hint that your patient might have a right ventricular myocardial infarction. So ask for a 15-lead ECG, serial troponins, chest X-ray, CBCBU and creatinine electrolytes, glucose and lipids. Also mention that prior to the discharge, you'll also do an echo to assess for left ventricular systolic dysfunction. So here the examiner might give you an ECG and would ask you to read an ECG. So here you can see you're looking for lead 2, 3, and AVF, ST elevation, and in the reciprocal leads, in the lateral leads, you will be able to see the changes, reciprocal changes. So what would be the treatment? Very, very important here. Secure the airway, breathing, circulation. Start with oxygen, IV morphine, aspirin after you rule out aortic dissection. Give them IV fluid, especially if the patient has low blood pressure. And then anticoagulate the patient. Do urgent cardiology consult to prepare the patient for cath lab so that they can have urgent percutaneous intervention. So key points to remember here is you will do a 15-lead ECG to rule out a right ventricular myocardial infarction. Give them IV fluids if the blood pressure is low. No nitroglycerin just because the blood pressure is low. And then for beta blocker, always rule out that your patient doesn't have right ventricular MI, any arrhythmia or heart block going on. Thank you so much for watching and dedicating your time to improve your OSCE preparation. And good luck for your preparation.